Now, our first speaker is a senior investigator at the National Institute for Health Research. Has published several articles on the care of older people, models of care, complex intervention, dementia-friendly communities, and a lot more. A fellow of the Queen's Nursing Institute. Please allow me to introduce Professor Claire Goodman.
Thank you very much, and thank you for the invitation to come and join this group. I owe Jackie Morris a lot. When I was a young researcher, she was the one that said, come on, you've got to get that proposal in and do some care home research, and the rest is history. So I'd like to acknowledge that at the beginning. I'm here to talk to you about the DACHA study and about information, data, and particularly about the information that we know about from our residents, from older people in care homes, but as importantly, the information we may collect, but we cannot access it. So what I'm going to do is give you a little bit of background to the care home sector, not a lot because this audience is deeply familiar with it. And I'm going to talk about the DACHA study. I'm going to reflect on the information we already collect, where it sits, and then I'm going to talk about how can we link the data into a minimum data set, and how can we address the needs of all the different groups who use information about our residents. So family, the residents themselves, staff, head office, commissioners, the regulator, and more policymakers as they plan for social care. So here we have the UK care home sector, and things have radically changed in terms of who the population look like. Almost half of newly admitted residents come from hospital. That means that they have recently had a major health event, and that affects the needs that they present with on admission. Paradoxically, outside of research studies, we know very little about the population. We have data, but actually it's the industry, it's the care home sector that tells us the most about this population if you don't look at the research, the individual studies. And we're still in a situation of where it's really mixed. So the average care home with nursing is still 30 beds. And without nursing is 28 beds. Now I know Hammerson has got many more. And as we see new build, the average is moving towards 70 to 80. So it's a sector that is changing. It has a huge market value because it's basically independent providers. The state does not provide long-term care for our older people. There are 3 times more care home beds than hospital beds in this country. And how is it funded? Well, 45% pay for it all themselves. 12% pay a top up on state funding, and a third are wholly funded by the state. The NHS pays for about 8% of residents because it recognises that the care they need is commensurate with care that the NHS would give if it could, and that number is increasing. But here, when we're thinking about information, when we're thinking about how do you organise data, it's worth noting that a third of our care home capacity is still run by care homes where the organisation owns 1 or 2 care homes. So they might have very good information systems within that 1 or 2 care homes, but how do you bring it all together to understand the whole population? And that's what DACHA is about. So here's a quick summary. On your left, the kind of data that we collect about care homes and the kind of information we collect about residents. But to illustrate this, consider what happens when somebody falls in a care home. And if you look at that blue column, this is all the information that a care home might record. They might talk about that they will record, they've talked to the family, they'll talk about when it happened, they'll do an accident report, they will possibly liaise with the GP, they'll record that they've done that, they will do a falls diary. Huge amounts of information, or held within the care home. And as the manager says, it's actually very difficult to standardize it, because when you have a visiting practitioner, they might ask for, well, what's the FRAISE score, which is the Frailty Falls Risk Assessment for the Elderly scale, anyway, you get it, and or the Falls Risk Assessment tool. So standardized good measures, but different practitioners asking for different measures, which falls on the care home. That pink one is the external organizations who may also collect information about the person with that fall, particularly if they need NHS support or follow up from the physio. And then finally, if it's a significant event, then it may have to involve the regulator, and certainly will involve a quality review and an audit possibly. So all this information triggered by one episode, siloed in lots of different places. So if we want to say how many people in care homes fall in this country, we can't. But we can do research that tells us, but then that's very limited by all the recruitment challenges. But then we had the pandemic, and that absolutely exposed everything we didn't know about the care home population, with some dire consequences in terms of recognizing the infection rates, recognizing the mortality rates. And having access to data was the difference between people becoming infected and not in some situations. So we have a post-COVID policy priority. The government has recognized that we need to do something. The latest care bill that is now on the statute book has actually specified we need a minimum data set. We need a data set that every care home will complete about its residents. It is also introducing a shared social care record where everybody will record the same information and not their nuances. That is a really challenging. And it is expecting that care home residents will be part of the health and care data system. They will not be out with the rest of it. So data, how do you marshal all that information? How do you do it? So the DACHA study is asking several questions, but I'm focusing on the minimum data set. We're interested in how to improve the quality of data that researchers collect, because researchers are as heterogeneous in what they think are the important assessment and outcome measures. What's going to be a useful and usable minimum data set that can be used for the care home population? And does this reflect the interests of residents, families who provide the care? Now that's really important, because there are minimum data sets in other countries, and historically they have all been developed by healthcare practitioners, which is good and right, but it does mean that some areas of information get overlooked or actually are not seen as a priority by those working in care homes. And how do you reduce the data demands on an already overburdened workforce? So I'm not going to talk in any detail about this, but essentially the DACHA is a series of linked studies. So the findings from one part of the study, the evidence reviews, feeds into how we've decided what we think should go into a minimum data set and how it should be implemented. And there's consultation that runs through the whole with all the different stakeholder groups. And this is just from our website, and so I'm just emphasizing it's not me that's doing this. There is a team of 14. I'm going to be talking to the work of members of the team and try very hard to acknowledge them as we go along. But if you're interested in the DACHA study, please just go to the website. It's just there in the middle, and you'll be able to see there's a whole range of resources and outputs. So what do we mean when we talk about a minimum care home data set? So it contains resident and care home data that different stakeholders need and use. So they can go to one place for core information. We're suggesting that it combines resident information held in NHS and local authority data. You can find residents now in that data, so you don't have to ask the care homes for that information, prescribing, hospital admissions, and so on, with data that care homes collect. And care home staff can use the minimum data set to discuss and plan care, but it can also be used to document care and be accessible, for example, to the regulators who then want it without having to generate even more data collection. And at a regional and national level, which is crucially what we have not had, you can aggregate all the data from the individual care homes to have a very good picture of what is happening in the care home population. Now, this is done by Barbara Hanratty, professor at Newcastle University. And before we embarked on working out what we thought a minimum data set ought to contain, we reviewed how it had been used in research. So North America, every long-term care facility has to complete a minimum data set. And what you see here is her review of 10 years of research and how researchers have been able to use that national and regional data to understand the population, to test their interventions, and to look at comparator groups who have not received the intervention. And it is thousands and thousands and thousands of residents that they can look at. We can't do that. The largest study, I think, in this country was a trial that recruited about 1,100. And that was considered huge. And then when you've got a minimum data set that is covering all that kind of information, it can then answer questions about the individual, about the care home and the system, and it can help improve quality, efficiency, and inform how health services are being used. So prescribing, assessment of clinical functional status, identifying people at risk within the care home population. So even though we have in the care homes people who by definition need extra care and support, there are smaller groups who need more support, who are at more risk, and therefore it is easier when you've got a larger data set to begin to make that kind of granular analysis. And we can look at hospital use and begin to see whether different types of care lead to more or less use of health services and what kind. We also looked at how these minimum data sets had been implemented in these countries. I say North America, some countries in mainland Europe, New Zealand, and parts of Australia and Scandinavia. And we found that yes, if you want a care home to complete a minimum data set as part to inform a national data set, you need a mandate. You need to make them. It has to be either policy or, as with North America, linked to remuneration and quality assessment. But if you want it to be more than an administrative exercise, you have to provide feedback. And that doesn't always happen, we've observed in the studies that we reviewed. And it has to be the basis for how everybody who is working in, with, or for care homes talks about the issues, so that they are using that as the primary resource. Again, that doesn't necessarily happen. So this is the learning that we've got about if you're going to have a minimum data set, how are you going to implement it? And those of you who work in care homes are thinking, there is no way I want a minimum data set sat on top of everything else I do. And that is crucial. It has to replace or fit with existing work. And a final, which was essentially some work from Belgium that suggested that the providers do have to invest in making sure that staff are confident in using digital methods of recording before you then expect them to be able to interpret the information they're looking at. So Barbara Hanratty also did a national survey to see what information care homes are already collecting. And this was in the middle of the pandemic. She got 273 care homes responded, but they represent about 5,000 care homes, because obviously if you're in an organization, the data you collect will be the same across the care homes. That's about a third of provision. We have about 15 to 18,000 care homes. And note the lack of precision on that number even. We cannot be precise. We don't actually, we struggle to know. We can talk about beds, but not about people. We can talk about numbers of care homes, but as they open and close, it's very difficult to know, and spread across England, and representative mix of ownership. And what she found was, what does everybody already collect? So the kind of things that you would expect: independence, activities, preferences, continence. Consultations with health professionals, that gets recorded, diet, nutrition, hygiene, communication. So thinking back to that Falls example, you can see the vast amount of information that care homes are routinely collecting. They're also doing clinical measurements, and that's interesting because 45%, and still care homes without nursing are just more than care homes with nursing in this country, don't have any on-site nursing, but obviously the pandemic has also had an effect. But so routinely doing these kind of measures for their residents. And from the point of view of the minimum data set, and apologies for the Bristol stool chart, for those of you who've never come across it before and probably don't want to again, the point here is using already standardized measures, validated ways of recording information. Now that obviously wasn't as high, but if you want a minimum data set, you want tools and measures that everybody is using and everybody's using it the same way for it to make sense. So what she identified was actually we've already come quite a long way in care homes picking up and using standardized measures, but not consistently. But it demonstrates that it's possible. But I'd just like to highlight here that only 15% were using any kind of standardized measure for quality of life. Now, they were recording, obviously, people's mood, but in terms of being able to look at it in a consistent way and be able to begin to say, well, their quality of life has improved, or we've got signs of deterioration, only 15%. And Jill tells me that if you were here last year, that quality of life was the topic. So that is something that we are prioritizing in the minimum data set and exploring. Data, again, paper records dominate in care homes, but computer records as well. So a lot of care homes working in hybrid systems, but more and more using dedicated care software. And that is, if you like, the beacon of hope, that if we cannot keep with paper systems, and that as more care homes move to digital ways of recording data, then there is more hope that we can standardize what is collected and aggregate it. So what are we proposing to do? What we are doing here is we are looking here at all the data that is already held about care home residents. Now, historically, that has been incredibly difficult to do because postcodes are often the main way of finding people. And obviously here, the same postcode would include a lot of people who wouldn't consider themselves in a care home. So, but that has changed. And so we can now extract residents' data from these different data sets held by external organizations. And then we are proposing to match the residents who've consented in our study care homes with the care data that we collect using our prototype minimum data set with the data held together. So we combine routine data with care home data that is held about individual residents. And that feeds in to the minimum data set. And it also brings in any regulatory data that comes from CQC and also any notifiable events about that person. So well, not suddenly, that's a complete lie. There is no suddenly about it. But essentially, there is a system that we are setting up to try and inform not only how individual care homes deliver care, so they can review with everybody who's delivering it, but crucially, regionally and nationally. So how is it going to work? We're working with two software providers, Person-Centered Care and Nourish. So we are not expecting staff we are minimizing the data that staff collect. This is data they are collecting anyway using the software. We have just identified the key information that we can standardize to then feed into and link with the routine data. It goes into the cloud in slightly different ways. Participating care homes will be the data controllers, and if we've got time for discussion, there are some unintended consequences of when you start sharing data beyond the care home. Software providers will do the pseudonymization, and sorry, I didn't explain, THF is the Health Foundation, who are then holding the data for us, and they have permission from NHS Digital to act as a data governor. I'm going to stop and with this slide, and then look at this woman. We have a public, I don't know who she is, it's one of these public domain photos, but one of our engagement when we were talking about quality life, you'll remember I said that actually this isn't measured in any standardized way in the majority of care homes. And so we were looking, there are lots of quality life tools out there, not all developed for care homes, but we looked at the ones developed for older people. And we discovered that this created a lot of tension amongst all the different people who use information. So the commissioners say, actually, all I want to know is what is their quality of life? I can get all this other information, but I want to know, and I can't get that data meaningfully. And so then we looked at tools. So what we did was we consulted with the different groups who would be interested in this, and we found, and we have defined quality of life as social relationships, attending to the person, a safe and supporting environment where you can make decisions and take risks. And this is different to health-related quality of life, which is arguably easier to measure. And there are measures that help you. And so then we shared in the consultation, and we found that people sort of recognized what it was, but struggled with some of the decisions we made. And one of the decisions was that we would have to do proxy assessment, because about 70% of care home residents would have difficulty replying to a quality of life. But that means somebody else is assessing your quality of life. And a lot of people struggled with that. And one of our public involvement people say, well, when you want to assess somebody's quality of life, you need to look into their eyes and see how happy they are. And I thought, okay, bit of a challenge to measure that one. But I think it captures that sense of the emotional, the connection, which matters, and how do you capture that? So at the end of my time, I need to say thank you. I need to absolutely stress that I'm just here representing these people who've led the work that I've told you about. So that's Barbara Hanratty, Anna Walters from the Health Foundation, Anne-Marie Towers from Kent, Adam Gordon from Nottingham, and there's an even bigger team. And I also have to say that although NIHR have funded this, anything I've said is my opinion and not theirs. And they would like you to know that. Thank you very much. So, the Q&A. So yes, I introduced the Q&A. So yes, so are there, sorry. So can I encourage people to comment or ask some questions? That was a bit of a breakneck speed, so if there was anything that wasn't clear, I'm very happy to come back to that. I'm Jackie, straight away, okay.
My name is Jackie Morris. I was a trustee and I'm now a medical advisor. I'm a physician who's been obsessed with care homes for ages. So I hope, where do you see the DACHA study in about two or 3 years? Where do you think it will be? What way?
Well, hopefully it'll be finished because we've only got a year to go. So the DACHA study was funded before the pandemic, and it was a bit of a niche interest. A lot of slightly nerdy care home researchers who said, we've got to sort out data. And 2 months later, the pandemic hit. And suddenly what was a sort of niche interest for those who work in and with care homes rocketed to the national policy priority. We were at a point at the beginning of the pandemic where the only way we could get mortality data was from the Office of National Certificates looking at certification of death, which is incredibly clunky and unhelpful way of doing it. And we do now have the capacity tracker, and we could talk about that if you like. But so what has now happened is that we are meeting regularly at every stage of the study, talking to the Department of Health and Social Care and talking to NHS England and saying, this is what we found. So we're saying this is the challenges of implementation. These are the consultation findings from different groups. These are the indicators we suggest you could extract from care homes and that would not inconvenience those using software if you standardize it. This is the information you can get from integrated care systems if you help them aggregate their data and you can match it to residents. So hopefully DACHA will be feeding into national law.
So what is the future for us if we wanted to measure those things? How do we join DACHA? Or how do you recommend that we change our recording systems? Because we're doing some of this, aren't we? But we're not doing it at all. Right. Or it's a lot of paperwork and I would
encourage you to drop the paperwork as much.
We are computerized.
So that would be the first thing. I'm a researcher. I can't tell you what to do until I've got my findings. So we're only, we're just testing the prototype minimum data set now. We're doing it with, hopefully, we're recruiting now 60 care homes in 3 regions. And I'm afraid Hammerson doesn't fall in our region because we have to work with the regional ICSs so that we can match the data. So we're working in Nottinghamshire, Surrey, and northeastern Cumbria.
No,
So you have to wait for the findings.
I have to wait for that.
Sorry.
Well, we are using computerized systems, but there's still paperwork that we'll have to think about. Does anybody else want to ask some questions? Jill?
Oh, this gentleman here.
My name's Andrew from the Jewish Deaf Association. Where does hearing loss fit into this particular area? I'm aware that a lot of care homes will track that somebody does have a hearing loss, but not what type of hearing loss, and most crucially, what sort of support that person actually needs. It could be that the person just needs a carer to speak in a certain way, or they have hearing aids, or that they need certain types of equipment. Yeah, so where does hearing loss fit into all of this?
So hearing loss is, we've modeled a lot of the, well, if you like, we did sense checking with minimum data sets that exist in other countries. They're all under license, so we can't copy them, and we've adapted it to reflect what could be implemented in English care homes. So yes, we are collecting information about how hearing loss is assessed and recognized. We are not collecting process data. The minimum data set will be recorded in the study twice, but we're recording outcome data. So if you look at the quality of life, if your quality of life is suggesting measures that things are not going well, then you would go back and say, well, why is that? And then you would, so people who have hearing loss is a classic subgroup that we would struggle to really gather large numbers of data about. So people who come into care homes with a history of deafness, and the minimum data set will allow us to plot and see what happens to these people and whether they receive more services or not. And that's the beauty of it. But yes, absolutely, all the sensory information we would record about residents. Yeah.
Hello, my name is Sana. Just a quick question. Have you considered including any oral health measures in the minimum data set? Because the population of care home is going to change massively over the next 10, 15 years. What we have now are people with either no teeth or just a few teeth, but obviously more and more people are retaining their teeth now. And 10 to 15 years from now, their oral health needs are going to change massively. So have you considered including any measures, oral health measures in that?
Yeah, I mean, I'm assuming that every care home does record what people enter with in terms of dentures and crowns and bridge work. Is that not correct?
Not really. I mean, most of the care homes we are working with, there's minimal data recording. Even like I'm doing this research study, we are doing as a whole team, and even like simple questions related to pain and everything, it's very hard to record. It's not included in their routine assessments or anything.
So pain would be recorded, their oral status, their oral health status would be recorded. And then I go back, and then there are other outcome measures that you would then begin to say, if people are reporting lots of pain, then it would be, and you have a large population, you can then go and say, well, is all this pain related, particularly for people with cognitive loss who can't tell you where the pain is, then you could begin to interrogate the data for those kind of questions. And that's a good example, again, of how the population is changing. You're quite right, 10 years ago, most people would have entered care homes with dentures, which is a lot easier to manage, but not always to keep. And I think what we're seeing already is, I'm talking about a minimum data set, and people who are interested in different topics say, oh, and you have got my topic on that minimum data set, haven't you? And I can just refer you back to that slide about what happens when someone falls. All those people are committed to knowing more about what has happened and why. The pharmacist has the medication triggered it. But what the minimum data set is, it enables the people to ask those questions of the data. And as long as the minimum data is enough to work with, you can then look to see what has happened. So for example, you would be able to say, we seem to see a lot of falls. I think it's because of people being startled because they haven't heard warnings or whatever. You know, is this a particular problem for people with significant hearing loss? Is this level of pain a particular problem with people who've been recorded as having a partial denture or crowns or whatever, and that they're now falling apart? Yeah.
Thank you.
So it's how you put the data together, but it's about standardizing the data. Otherwise, yes, every care home will record it slightly differently. So we're trying to standardize how that basic information is recorded.
Thank you. Thank you very much for your presentation. I'm fascinated to see the outcome of the DACHA study. I wanted to ask, how are you linking with the regulator with regards to the outcomes? And do you feel that this study and the minimum data set, once it's implemented, will have an impact on the quality of care provision?
Well, that's the million-dollar question. So, and that's about care-related quality of life measurement. And yes, we are talking to the regulator a lot, and we consulted with them on the tools that we've decided to use for quality of life measurement, which we know are standardized, we know have been used in English care homes, and from a research point of view, we know that staff can consistently complete them. And the regulator was very concerned about some of them because they said, this doesn't seem to be emphasizing person-centered care. We want narratives that tell us the process of care, and we are including outcome measures that are taken every 6 months. And so we had a very extensive discussion about, well, if you have this measure and you see the outcome measures deteriorating, that would trigger you to go and look at the process of care. So we're not saying that all the other data that care homes collect is going to be thrown out. So for example, care homes will be recording how often they turn somebody who's assessed as having a tissue viability risk. That won't go into the minimum data set. We will record their tissue viability, and we will record whether there appears to be an issue. But then the other data, which is in the software, can then help you track what might the possible reasons and interrogate it. But yeah, CQC are very interested in what we're doing. I'm very concerned that this isn't too reductionist and doesn't move away from absolutely delivering person-centered care, which is why the quality of life measures are so important. Okay, and I've just been told I'm finished. Thank you.